Guys, we're continuing with the cardiovascular system. The lecture now is the ECG leads or 12 lead ECG, and what do we mean by the 12 leads and where do they attach and what do they show us. This is not about the pathologies, instead this is the physiology. We'll do the pathologies when we'll do the arrhythmias and the infarctions. Okay, so the leads that we have are called as 3 bipolar limb leads, 3 augmented leads, I call them A leads, 3 augmented leads, 6 chest leads, and 1 earth. So let's see what these leads are, and then we'll start discussing how to see the ECG and what do these leads mean. So first of all, 3 bipolar limb leads. So lead number 1 is attached to arms, and so this is the lead number 1. Ideally, I hope you understand that what happens is I'm just drawing a straight line, but ideally the lead 1, for example, will go from here and the negative end goes to the voltmeter or electrocardiograph machine's negative end, and the positive end goes to the ECG's positive end, and then the machine does the rest of the function. So that is how it is connected, but we say abstractly that this is the lead 1. And look at this, keep an eye on the positive side. This is the positive side. This is important. Secondly, the lead 2. Why do we call this bipolar though? We call it bipolar because there is a negative end and there is a positive end. This is lead 1. Then is lead 2. Lead 2 is connected, one end, negative end, to the right arm and the positive end to the leg, left leg. Remember this, left leg. The leads that have L in them, for example, the left leg or left arm, these are always positive. And of course that means right is always negative. So here the lead number 2, abstractly we'll say it goes like this. Negative end is here, positive end is on the leg. You can also see it this way, that if this was the ECG machine, same machine, I don't want to clutter up here, same machine, then the negative end from here is connected to the negative end and positive end from here is connected to the positive end. So ideally this is the circuit, however we make it like this. Same is the case for the lead number 3. So this was lead number 2. Lead number 3 connects like this. Slightly crooked, but hopefully that's okay. Again, positive end is here and positive end is here and the negative end is here. So left leg has 2 L's, has 2 positives. Left arm has 1 L, has 1 positive. Right arm has no L, so there are no positives there. All negatives in all case. Again, this one you can also see that in the ECG machine, the negative will go and attach here, the positive will go and attach here on the ECG. Right? So that is the way these leads are set up. These are bipolar, these are limb leads. Now the question is, how do we understand the electrical activity and what do they do for us? Look, what these leads are doing is, so right arm, left leg, what these leads are doing is they are acting as cameras to look at the heart. The question is, how do we look at the heart? What are the ways to look at the heart? So let me show you the position of the heart in these slides and then we'll come back and talk about the leads here. Here is the heart as it appears in the rib cage. So if you see here on this heart, Predominantly it is present on the left side of the rib cage, it is present more over there. Then the left atrium, left ventricle is present on this side, right ventricle is present here. Somewhere below the sternum, which I have removed in this diagram, is the interventricular septum. So this is the position of the heart inside the chest cavity. Also see here that this is a view of the heart where we have cut a horizontal section and we are looking at the patient from below. This is the left ventricle, this is the apex of the heart, this is the right ventricle, and here is the base side. This is the interventricular septum. So keep this in mind, that if you look at the heart from the sternum, from both sides of the sternum, if you peek in, and if the heart is open, you look at the interventricular septum that is going to be present between the two ventricles. So keep this position in your mind. This is a lead 1 here. Lead 1, negative on the left arm, positive on the, negative on the right arm, positive on the left arm. This is lead 2. Lead 2 is right arm negative, leg positive, left leg. Lead 3, left leg positive and left arm negative. We'll also talk about the augmented leads, which use the Einthoven's triangle. So let's talk about that now before we continue further with the limb leads and chest leads. So the way these leads are looking at the heart, if we put the heart over here, the way these leads are looking at the heart is that the lead 1, positive side is this, it is looking at the heart from here. Lead 2 is positive end is this, it is looking at the heart from here. Lead 3 is looking at the heart from here. Remember the cardiac axis lecture in which we said if I draw this on the cardiac axis, the axis, remember, horizontal was the lead 1, 0 degrees to 180 degrees. Then vertical was lead AVF, we'll draw that right now, and then lead 2 was 60 degrees and lead 3 was 120 degrees. This is the, if you take a coronal section, so if you cut me, for example, from here all the way half and you insert a circular thing, and in the center of that thing is the heart, if you have a circular disc, this is that disc and this is the views of the leads. What that means is this, look, lead 2, for example, this is the lead 2, it looks up like this. Lead 3 looks up like this. So it looks really on the inferior side of the heart. Lead 1 looks down, and because the positive is on the left side, so almost from the left side. So that is how to interpret these. Now let's talk about the augmented leads. Before we talk about the augmented leads, first we need to talk about Wilson's center, electrical center. What that is this. What Dr. Wilson said, that if you can sum or average, if you average all the electrical potentials from all the leads, that average is going to create a mean that is somewhere in the pubis area. That is the mean potential that is somewhere in the pubic area. This center is called Wilson's center, and this center can be used as a negative lead, and then you can put positive leads in various places. So here is how we work. What we do is we say augmented. So look, this is the left, this is right arm, this is left leg, right? Left leg. So if you add an augmented lead over here, what that means is, I'm going to make it in black. If you take the positive from here and attach to the ECG, and if you take the average of all the other and attach that to the negative, then really pay attention now. Then what we are seeing is we have a lead like this. Negative is here, positive is here. This lead is looking at the heart from the right side. So it is a camera attached here on the shoulder and is looking at the heart from the right side. This is augmented VR, augmented voltage lead. So this is the right side augmented voltage lead. If we do the same thing on this side, what we do is we take the positive, let me continue making it in black. We take this lead and attach it to the positive end. This is the positive end, this is negative end. And we take this lead from the center and attach it here. Then that becomes this new lead, a abstract lead. You can't see the lead here, but that is all mathematical calculation. What now we've gotten is, we've gotten a new lead that looks like this. This is the augmented voltage based left lead. And how does it look at the heart? It looks at the heart as if there is a camera here and that is looking at the heart like this. AVR was looking at the heart like this from the shoulders. So that is why the AV augmented VL, augmented V, yes, and augmented VR are shown as -30 and -150 degrees. They are looking at the heart from here. So we have cameras that we are attaching to look at the heart in a circular way. And also we'll attach cameras that would look at the heart from the front and the side. So we'll have 12 cameras attached and we'll look at the heart. So these are the AVLs and AVRs. So what do you think AVL is going to look at? It is looking at the lateral side of the heart, which is what? Lateral side of the heart on the left side is the ventricle, left ventricle. Okay. How about the AVF? So AVF, again, instead of making more, I'm just going to make it this way, from here to the foot. So the positive end is on the foot. That is why it is called AVF, augmented voltage based foot lead, and it looks up from here towards the heart. What do you think it's going to look at? Inferior surface. So before we go to the chest leads, now we've gotten the augmented leads and the limb leads. What do you think? What is this central piece? This is called the Wilson's mean center for the voltage. It is a calculated center. It can act as a negative. This is the same negative center that will be used for the chest lead as well. These are the augmented leads are called unipolar because this is taken as the center, common center of the body. Okay, so now what kind of view are we going to look at? Pay attention here. We are looking at the left lateral side of the heart. That is left ventricle. We are looking at that through which leads? Look at this here. Please don't memorize the tables. I've seen students putting the tables in front of them and saying, this lead is this lead is, that's not the right way. Just look at it. Lead number 1 is looking at the heart from laterally. So 1 is lateral. How about the AVL is also looking at the heart from the lateral side. So AVL also looks at that. So lead 1 and AVL would look at the heart from the left lateral side. How about the lead AVR? It looks at the heart from the right lateral side. It is also called a lone lead. It is also called a forgotten lead. Why? Because AVR is the opposite of AVL. So if you really want to extrapolate what AVR should look like, take the AVL and inverse it. Because one is seeing from here and the other one is seeing from here. They're seeing at the same exact thing. The only thing is their electrical current that they are going to see are going to be reverse of each other. So if the current is going this way, then this is going to see as positive, but this is going to see that as negative. If the current goes this way, then this is going to see that as positive and this is going to see that as negative. That is why AVR is usually not used. It is not used because it doesn't provide us useful information. It is not used because that information can be extrapolated from the AVL, from the lead 1, from the lead 5 and 6 as well. So that is why it is a lone forgotten lead, but it is there. It looks at the heart from the top right side. Okay, how about the AVF, the foot lead? It is looking at the inferior. Who else is looking at the inferior? The lead number 2 and the lead number 3. Let me make those in blue arrows. This is lead 2, this is lead 3, this is lead 1. Got it? Got it? Okay. How about chest leads? Look, chest leads are very simple. We are seeing the heart. Left side is this is left, this is right. So what you're seeing is this is the left ventricle, this is the right ventricle, this is the interventricular septum. This is why I actually made this diagram here. The chest leads are also called unipolar leads. They also actually use the negative. Without a negative probe, no lead will ever work. Voltage meter does not work with one lead. This Wilson's lead is going to act as a negative end. So that means, actually, this is the excellent doctor point. That means that even for the chest leads, when they are present here, these chest leads are all positive ends and the negative end is here. So this is how the chest leads are looking at the heart. It is funny. So the negative end is somewhere over here. So if you bring the patient's body down here near the pubis, there is a negative end. At the belly button, pubis is a little lower. So negative end is there and positive ends are placed here. So we place one probe here, another probe here, then one probe here, one here, and I'll tell you about the views, exact placement, but this is how it looks. So the lead V1 and V2 will look at anterior and septum. So when they look down from here, they actually look at the septum. So why the septum? Why not the ventricle? Look, the ventricle is sitting like this and the septum is this, and you're looking in from here. So when you're looking in, what are you going to see? The septum. So V1 and 2 are actually called anteroseptal leads. They look at the septum. Lead 3 is looking at the anterior surface of the heart. 4 is looking at anterolateral, not the septolateral or anteroseptal. This is anterolateral. And 5 and 6 are looking at the lateral. So 6, 5, 4, 3, 2 and 1. So we actually are looking at all the left side and the left ventricle and the septum and the anterior surface. Why not the right ventricle? One, we can extrapolate that from the left. Secondly, most common diseases, most common ischemic problems or hypertensive problems or infarctive problems are on the left side. Thirdly, left side is the most bulky one and has the most electrical current, so it is easy to start picking up the currents from that side. So there are many reasons to look at that side. These are the chest leads. So let me show you in a diagram how to place the chest leads. So now we understand that 5 and 6, V5 and 6, these are the chest leads, they are looking at the left lateral side of the heart, which is the left lateral side of the left ventricle. What else was looking at the left side? AVL was looking at the left side. What do you think about 1? 1 was also looking at the left side. So basically 1, AVL and the 5 and 6 look at the left lateral side. How about 2, 3 and AVF? They all look at the heart from the inferior. It's simple, you have it here. Now how about AVR? It looks at the heart from the right side, but it is a reciprocal of AVL and 1 and 5 and 6. How about lead 1 and 2? They look at anteroseptal, interventricular septal issues or the electrical activity plus some part of the anterior lead. How about 3 and 4? They look at the anterior surface of the heart. One more thing is important to note. V2 and V3 are supposed to be almost overlapping. That means if V2 is looking at the septum and V3 is looking at the anterior side, then V2 is also looking at some part of the anterior surface. Similarly, if V4 is looking at the anterior surface and V5 is looking at the lateral surface then V4 is looking at little bit of lateral and V5 is looking at little bit of the anterior surface. So wherever there is a change in the tissue that the lead is seeing, it overlaps with the previous lead. Just keep that in mind. Now with this, let's look at quickly how these leads will pick up the problems. First important thing, lead T2 is our hero. Why? Because lead 2 is the most in line with the cardiac axis. Remember, cardiac axis we did, it is 59 degrees centigrade. Oh, why did I say centigrade? 59 degrees, and lead 2 is 60 degrees. So this is almost the same direction. That is why normal hearts, best action potentials can be seen in lead 2. Hero is 2, not 1. So keep looking at the lead 2 whenever you look at the lead. So that would give you the best current amplitudes. Similarly, for the ventricle left side, V5 and 6. So let's say a patient has developed inferior infarction. What leads would show you the problem? What leads look at the inferior side? Lead number 2, lead number 3, and AVF. So inferior wall, and what kind of an artery will cause the inferior wall problem? Right circumflex artery, right? How about if there is a problem on the anterior surface of the heart? Who is going to look at that? Remember, we have V1, V2, so that is the anteroseptal side, V1, 2 and 3. So if there is a problem with the interventricular septum, which could be left anterior descending, or problem with the anterior surface, which is also left anterior descending, then V1, 2 and some part of V3 will give you the septum and anterior surface of the heart. How about if there is a problem on the lateral side, which is the most common side? Lateral, left ventricle. And before that, what is the artery for the anterior surface? Left anterior descending. Now how about the problem, infarction on the left side of the heart? That would be left circumflex artery, and who is going to look at it? V5 and V6, even lead 1, even AVL, but primarily 5 and 6. Now you say, why don't we want to see the AVR if there is a problem on the right side? Well, you can see the opposite of all of that in the AVL and 1 and 5 and 6. That is why you don't really care too much about the AVR. So with this, let us now quickly look at an ECG and see the relationship of the leads together. So lead 2, 3 and the AVF, they look at the inferior surface. This is the inferior surface. Then lead 1 and AVL with lead 5 and 6 look at the lateral surface. Then lead 1 and 2, V1 and V2 look at anteroseptal part, and lead V3 and V4 look at the anterior surface of the ventricle. Okay, so if you wanted to know about the leads and the general properties, we are done. If you want to hang around, we're going to go a little deeper and talk about the Wilson's lead and talk about the augmented lead math. So just a quick math, if you don't want to listen to it, you can just stop here and move on. So look, the guys who are interested, augmented lead, let's say augmented voltage based lead left, means you take the left lead voltage in the left arm, and then you subtract the voltage sum of the remaining two leads. So what are the two leads? We have, so the left is covered, so right arm plus left leg. So this becomes augmented lead. Similarly, AVR will be right arm here and the other two leads here. AVF will be foot here or the left leg here and the other two leads here. So that is how we calculate that. About the Wilson's lead, that is even simple. So Wilson's lead is basically, you take all these three, so left arm plus right arm plus left leg, and you average them, that is divided by 3, and that gives you the lead. One more thing here, in Einthoven's triangle, Einthoven said that lead 1, 2 and 3, if you know the voltages of any two leads, you can do the voltage of third lead. Or he said it this way, he said if you add the lead 1 plus the negative of the lead 2 plus the lead 3, it should be 0. So that is the Einthoven's triangle. What that means for us practically is that if you have lead, let's say 1's potential, then if you have leads 2's potential, then you can extrapolate, you can figure out that what should be the lead 3's potential, and you can see if the ECG is working correctly and you are looking at the right readings. Similarly, if you have leads 3's potential and 1's potential, you can extrapolate through. So any two leads if present, you can get the third lead, and that is the Einthoven's triangle. So just very quickly, the math for the augmented lead, Wilson's lead and the Einthoven's triangle. Thank you very much.